Assalamu alaikum. Good day to all of you, dear doctors. Welcome from our MRCS Academy. Today, I'd like to share a brief discussion on burn topics, which is most important for MRCS Part B or OSCE examination. Here, you'll find the questions about the calculations of bonds, such as calculate the surface area of the bonds. You'll follow the Wallace rule of 9 shares. Let's find that in case of faint, here is 4.5%, and in case of chest injury, burn injury, here 9%, and in both hand, front and back, 4.5% plus 4.5% in equal to 9%. And in case of abdomen, here is 9%, and in case of genitalia, here is 1%, and in legs, in case of front part, 9%, and in back parts, here is 9%. In case of chest, back, 9%, and on abdominal area on back, here is 9%. Then next question, follow that the management of the barn. You will manage according to the ATLS ABCD resuscitations. In case of primary survey, you have to follow areas 3 parts: look, feel, and listens. Look for the signs of airway burns and inhalation injury, and intubation of their edema if required, and high flow oxygen. Here's the look for facial burns, facial hair of scrotum, and it will cause edema. In case of breathing, the tracheal pulmonary burns can impair effective gas exchange and steatomy for circumferential chest wall charts. Now, circulations assessment and manage here is 2 whiteboard large corona and urinary catheter and fluid resuscitations by crystallite usings. Here shall follow the Parkland formula in case of total burn surface area when would be greater than 50% in adult, and in case of child here would be the greater than 10%. Now the Parkland formula is 2 ml into total burn surface area and into patient weight. In case of film burn, hence the 2 ml would be 2 ml, and in case of children it would be 3, and in case of electrical burns, here's we have 2, here's 4 ml. Okay. Now you'll follow in case of deep and more extensive burns may require a blood transfusions, and consider CV lines in insertion on interCS line if efforts not essential. In case of disability, you would look for Glasgow scales and pupils and quick neurological examinations or exposure environment, remove the clots, and GLRE, prevention of hypothermia. Now we have to follow the secondary surveys such as baseline trauma investigations, such as blood work, full blood count, and arterial blood gut analysis, and questioning, and chest X-ray maintenance, peripheral circulations in circumferential extremely burns, doing fasciotomy, gastric tube insertion in case of experience of nausea, vomiting, or abdominal distensions, or when patients were more than 20% of total burn surface area. Analgesics and sedatives are given after correcting the hypoxemia, wound care, and cover with clean sheets, avoid the confess, don't remove blisters, can wash with normal slice if contaminated. Okay, just remove the blisters if it is contaminated. Antibiotics is not recommendable unless there is signs of infections. Okay, tetanus immunization and transfer to burn center aging resuscitation. Okay. Now some instructions regarding how to assess the adequacy of fluid therapy, and you'll answer capillary refill and urinary output. Then you have to ask. Then you would ask what else? Answer pulse, blood pressure, central venous pressure, invasive cardiac monitoring, and joint skill conditions, and temperature, color, signs of hypovolemia. The next question should be happened as why not giving colloids? Would like to answer as it is because it will pass to extravascular space and can cause paradoxical augmentation to interstitial space. Okay, and because it may carry more side effects and more expensive. Would you consider giving blood pressures? Yes, if only indicated. If hemoglobin is less than 8 or equal to 8 in case of post-traumatic, or if it is 7 or less in case of chronic anemia, here's the uh, blood transfusion is indicated, and also is indicated in case of acute drop in hemoglobin and continuous bleeding, and in case of steatomy. Now I would like to share about the complications of the burns, shock, hypovolemic shock due to plasma loss following loss of skin cover, or leads to hypotension, tachycardia, increased systemic vascular resistance, and a fall in the cardiac output. Then next, sepsis and acute respiratory distress syndrome can occur. Renal failure, circumferential burns, such as the ischemic limbs, or in chest requires hysterectomy. Electrolyte disturbance also may occur: hypo or hypernatremia, hyperkalemia, hypocalcemia, and hypophosphatemia. Coagulopathy also occurs due to disseminated intravascular coagulations and hypothermia, hemolysis leading to hemoglobinuria and anemia. Next question is red and blistering has superficial or deep burn. That's the second, or superficial partial burns. If you follow this chart, you'll find that in case of superficial burn, here also pain, redness, and mild swelling. And in case of superficial partial, so the blisters, pains, and in case of deep partial, you'll find white. Leathery, little bit finless, and in case of full thickness here the insensation and scar formations. Now, where do you want to manage these patients? I would like to manage it in ITU burn unit. In case of ITU chest X-ray is taken, tell me what is the findings. Here's the chest X-ray. Here the findings is bilateral infiltrates on chest X-ray cause pulmonary edema. You have to also answer as the differential diagnosis such as pulmonary edema due to volume overload or pneumonia. Now, how to differentiate acute respiratory distress from pulmonary edema? I think I'd like to share in next session about the acute respiratory distress syndrome. Okay, thank you all of you for watching my videos. Thank you, dear doctors.